We're going to talk about EEG. I think everybody who has a history of seizures or a family member with seizures should have some understanding of your EEG. As an epilepsy doctor, I like to show my patients their EEGs. How many people have seen an EEG? Oh, good. How many feel like you understand your EEG? Not maybe as many. Okay, well that's good. I think it's even more important now because now we know our medical record systems, they automatically populate your EEGs into your charts, so you can log in and see those reports yourself. So now you can read those and see those words, so I think it's maybe even more important that we understand what those words mean and what EEGs look like. So we're going to have a little lesson on EEGs today, and then maybe it'll be easier. I have a little cough. I'm not contagious. I just had a procedure and my airway's a little irritated, so bear with me. I'm going to try not to cough through the whole lecture, but do the best I can. All right, just a little epilepsy overview. Everybody here has probably some relationship or someone they know or someone they work with or a family member with epilepsy, but I like to remind people every time I give a lecture about kind of the state of epilepsy in the country and why it's so important that we do events like this and we talk about epilepsy. So just in case people aren't aware of the data, 1 in 26 Americans will develop epilepsy. It's about 3.5 million people worldwide. 1 in 10 people have a seizure, so not everybody who has a seizure goes on to develop epilepsy. There's about 200,000 new cases of epilepsy a year, and a more sobering statistic, about 50,000 people will have an epilepsy-related death. Epilepsy is more common than multiple sclerosis, cerebral palsy, muscular dystrophy, and Parkinson's combined. I just note that because even though we're in Epilepsy Awareness Month, as you know, there's a pretty significant stigma attached to epilepsy, and that limits our ability to raise awareness and advocacy for epilepsy, which is one of the reasons we're all here these couple of days. And this limits the amount of research and funding that we get for our disease. And this limits our ability to find good treatments. And these other diseases, which are much less prevalent, actually have more awareness and more funding and more research. So this is something we all need to continue to work on. We know after failing 2 anti-seizure medications that are appropriate for their seizure type, there's only a less than 10% chance another medication will work. It's actually a 4% chance, and that leads us to about 30 to 35% of patients that have what we call drug-resistant epilepsy. Those are just the statistics. And we're going to talk about different EEG findings that are applicable to different seizure types. So I just want to review the terminology. So when I'm explaining seizure EEG findings, that you have some understanding of the different seizure types, that we're all using the same words. Epileptologists don't agree on very much. When we put a big group of us together in a room, we mostly argue. But there are a few things that we have agreed on. And we come up with these new classification systems. I think they do this so that we have to update our slides every couple of years. So we keep changing the names of things. So you may have been diagnosed with a type of epilepsy 10 years ago, and now your doctor gives it a different name. It's not because your epilepsy's changed. It's because the epilepsy doctors got together. I guess we were bored and had nothing else to do, and we came up with new names of things. So these are the current classification system. This has changed in the last couple of years. So you may have been told that you had complex partial seizures, and we don't use that word anymore. You still have focal seizures, but that's not the word we use. So just so we're all on the same page, this is how we classify seizures now today. Again, this may change. Next year, we may have new slides to look at. So we have seizure type, and the seizure types can be classified as focal, meaning they start in one area in the brain. A focal seizure can look like anything depending on where in the brain it comes from. We have generalized seizures where the whole brain fires at once, and then we always have an unknown category if we can't figure it out. From there, we go on to the epilepsy type. Depending on what seizure type, you then have an epilepsy type, which can also be focal, generalized, or some patients have what we call mixed, where you have both focal and generalized seizures. And then we go on to an epilepsy syndrome name. The syndrome name takes into account other features, such as your MRI finding, your genetic testing, your clinical history, your neurologic exam, your cognitive abilities. This all comes together to give you a syndrome name. We then want to figure out why you have epilepsy. So we look at structural findings. This is going to be the MRI picture. We look at genetic findings, if there was an underlying infection, something abnormal with the chemicals in your body, a metabolic finding, or maybe an immune disease. And we try to give you one final answer that says this is why you have epilepsy. Now, can we do that for everybody? No, but we try real hard, and we're getting closer. The more underlying diagnoses we find, the more able we are to give everybody an answer. Now, when we want to dive a little deeper into focal seizures, of course, there's subcategories. It's not just as easy as saying focal seizures. We have focal aware seizures, which is what we used to call simple partial. These are where patients are aware and able to communicate and know what's going on around them during their seizure. And then we have focal impaired awareness, where there's a change in the level of awareness. We have motor and non-motor seizures, and any of these seizures can secondarily generalize and become convulsive seizures. Then we have generalized seizures, where we have motor seizures and we have non-motor seizures. And then we have unknown, where it's unclear based on the testing we do what type of seizure there are. Now there's even subcategories, which I'm not going to go into all of them, but you can see that we can classify these seizures into even more detailed types. So under focal seizures, you can have motor seizures that can be more subtle with just what we call automatisms. Maybe there's just some picking movements of the hand or some unusual behaviors. You can have a drop seizure where you have kind of a head drop or an atonic movement. You can have non-motor seizures where the patient may just feel something, get a funny smell or a funny taste. In the generalized category, we have tonic-clonic, which is what most people think of as a grand mal seizure, where there's generalized stiffening followed by jerking, or you can just have generalized jerking or just generalized stiffening. Clonic is the word we use for jerking, and tonic is the word we use for stiffening. A myoclonic seizure is a quick jerk. You'll often have this type of seizure, this type of feeling when you're falling asleep at night and your body jerks. That's sleep myoclonus. Don't worry, everyone doesn't have seizures. But you can have that epileptic, and that can be an epileptic seizure. You can also have a staring seizure, what we call an absent seizure. That's a generalized non-motor seizure, where you just stare off and there's not any other associated features. So these are some of the words we're going to be using. We're not going to talk about every seizure type, but I have EEG pictures of most all of these, so I just want to make sure that we're all on the same page. All right, so probably a lot of people in this room have had an EEG or had a family member or loved one have an EEG. These are the stickers that we put on your head when you have an EEG. This is looking at the head from the top down. This is the nose up here in the front, and these are the ears on either side. The electrodes are labeled based on where they are in your head, so that when we read the EEG, we know what we're looking at. So if the technologist who puts the electrodes on knows where to put them, and these little dotted lines, these are actually measurements. So your head is measured, and these electrodes are placed a specific distance from each other, and distances from different markings on your head, so that they're always in the same place. You always want to make sure the FP1 and FP2, which are those electrodes that are on your forehead, are in the right place so that we can look at the brain waves and accurately figure out where things are coming from. There's some standard protocols that we follow. The even numbered electrodes are always on the right side of the head, and the odd number electrodes are always on the left side of the head. So this is just standard. This is the way EEG is done when it's done. So you can see the FP2, frontal polar, those are the ones on the forehead, FP2 on the right, FP1 on the left. As we go backwards, F8 is another frontal electrode, hence the F. It also covers a little bit of the front of the temporal lobe. Let me go back 1 minute. We know that we have 4 lobes in our brain. We have the frontal lobe, which is in the front. We have the temporal lobe, which sits down by the ear. We have the occipital lobe, which is in the back. And we have the parietal lobe, which is kind of in the middle. So these letters and numbers are coordinating with those different lobes. The T electrode sit on the temporal lobe. The O electrode sits in the occipital lobe. The P electrodes are sitting over the parietal lobe. And then we use C to denote an area that we call central, which is really over the motor strip, or the area that controls your motor activities. We use these Z letters to indicate the electrodes that are right on the top of their head. They go right down the middle of the top of your head. And then the A is over the ear. We use these to help us keep track of some of the electrical activity. Now, after we put all these stickers on, we have to look at this electrical activity on a piece of paper or on a computer. So we have to be able to monitor this electrical activity, and we do that by comparing the electrodes to each other. So for instance, we're going to compare the electrical activity being generated by the brain cells under this electrode to the electrode next to it. And by determining which electrical activity is more negative or more positive, the wave on the page is either going to go up or down. So depending which electrode is more negative or which electrode is more positive, you're going to see a wave on the page go upward or downward. And then we're going to compare the electrode F7 to the next electrode near it. And we can compare electrodes to each other in all different types of patterns and organizations, so we can look at all the activity in the brain. The most common way we do this is diagrammed here with the yellow highlighter. So we'll compare electrode FP1 to F7, then we'll compare F7 to T3, T3 to T5, and T5 to O1. And those 4 rows will be lined up on the page in a grouping. And then we'll compare FP1 to F3 and come down this way. And those 4 rows will be in another grouping. And then we'll do the same thing on the right-hand side. And then we'll compare these middle ones. Now, if you look at this diagram, how this looks on this page, those kind of look like bananas. So we call this a montage, or this organization of electrodes, a double banana, because it looks like bananas, so why not? So this is, it's not really that complicated, right? So this is the most common way we look at EEGs, what we call a double banana montage. But it's really just a way of comparing electrical activity between the stickers that we've put on the head so we can monitor electrical activity. Keeping in mind that the odd numbered electrodes are on the left and the even number electrodes are on the right. So EEG is really not that complicated to look at if you think about your brain as being symmetric. So just like your body's symmetric, what your right side of your body looks like, the left side also looks like, your brain is symmetric. So the electrical activity coming from the left side of your brain should match the electrical activity on the right side of your brain in the same area. So if we're looking at electrical activity in the right front, it should look like the left front. So that's one easy way when you're looking at your EEG is to compare the left and the right. And if they look the same, then probably things are okay. If something looks different, then the trick is trying to figure out which side is abnormal, because all you can see is that something's different. So we have to have some reference point of what normal looks like to then try to figure out which side that looks abnormal is the side that we need to worry about. So when we look at an EEG, the first thing we do is try to look for normal patterns, because we all have normal patterns when we're awake and our eyes are closed, and we have normal patterns when we're drowsy. We have different patterns when we're asleep, and we have different patterns when we make you do things, such as breathe deep or if we flash lights in front of your eyes. And then there's abnormal patterns. There's abnormal patterns that show us an increased risk for seizures, and there's abnormal patterns that may tell us there's something wrong in your brain, such as something in your brain like a tumor or something that shouldn't be there, or if you've had a previous injury to your brain, such as a stroke, we can see that on EEG, or if you're just really sleepy because you got a lot of medication in the emergency room. So we can see all those things on EEG. So some of the abnormalities that we're looking for are abnormalities that may be associated with seizures. These are the ones that we're most interested in patients who have a history of seizures or epilepsy. These waves are called things like spikes, sharp waves, and spike wave complexes. These are abnormalities that we see in patients who have a history of seizures or may have a tendency to have seizures. Now, it's not a one-to-one guarantee. You can have an abnormal brain wave that tells me you may have a history to have seizures or may be more likely to have seizures, but you may never have a seizure. So just because you have this abnormal pattern on your EEG doesn't 100% guarantee you're going to have a seizure. It may mean that you've had a prior injury to your brain and it's capable of making seizures, or it may mean that you have a relative who has a history of epilepsy. We know there are some genetic epilepsies that give this indication that other family members may have irritability on their brain and never have seizures. So when we first started studying the genetics of epilepsy, we were studying large families where there was a history of epilepsy in the family, and we did EEGs on everybody. And we found some relatives who had very abnormal EEGs and had lived very long lives. Sometimes they were in their 80s and 90s and had never had seizures, even though they had these same EEG abnormalities on their EEGs. So we know there are often relatives who have abnormal EEGs, the same EEG pattern that the relative with epilepsy has, yet they've never had seizures. So just because you have an EEG that shows an abnormal pattern that we know can lead to an increased tendency for seizures, it doesn't guarantee you're going to have seizures. So it's not 100% guaranteed just because we see an abnormal wave, you're going to have seizures. So what do these waves look like? This is a picture of a spike. A spike is a pointy wave. The doctor who trained me in epilepsy when I was doing my fellowship told me that a spike is something that if you sat on it, it would hurt. Right? So that's, I think, pretty good. So if you look at this wave here, it's less than 70 milliseconds. That's how we measure it. But this is a pointy, sharp wave. If you sat on this, it would probably be not comfortable. Whereas the sharp wave is more rounded. It's not as pointy. So that one's not quite as bad. A spike is kind of the worst wave. A sharp wave is not quite so bad. And a slow wave is much less pointy. It's more sloped, kind of like a mountain. So slow waves aren't as epileptic. So the most epileptic is the spike, the pointy wave. The sharp wave is less epileptic, less likely to be associated with seizures. And the slow wave is the least epileptic. So if we're going through the sequence there, that's what we see. This is just another picture showing you some sharp waves, some spikes, which are definitely the most problematic. We have some spike with the aftergoing slow wave, which we sometimes see. And then here we have a cluster of spikes together, what we call polyspikes, where the wave goes up, down, and then up and down again. So if it goes up and down more than once, we call that poly. Poly means more than one, polyspikes. So this would be maybe more concerning than just having one spike. All right, now when we're trying to figure out where these waves are coming from, the whole goal of reading EEGs is not only to find the abnormal waves, but be able to tell you where in your brain they're coming from. Are they coming from the frontal lobe or the temporal lobe? Is there an area there that may be treatable with some type of surgical procedure? In order to do this, we have to figure out what part of the brain the wave is coming from. So we do this by looking at what's called a phase reversal, which is just a complicated way of trying to identify the focus for the electrical activity. So if we look at this first box here, we see that we have these electrodes. The frontal polar electrode, that's the one on the forehead. The F7 electrode, which is the front of the temporal lobe. The T3 electrode, which is the main area of the temporal lobe. And then the T5 electrode, which is posterior temporal. And then O1 is occipital. And we see in the first two, we see a little downward blip. Then we see a much bigger downward blip. and then we see a big upward blip, and then a little upward blip. And you see here between F7T3 and T3T5, those points come together. So we call that a phase reversal when the points come together, touching each other. And if you look to see which electrode is shared, it's T3. You have F7 to T3, then T3 to T5. So T3 is the electrode in common. So that's going to tell me that this abnormal discharge is coming from T3. And because the points are pointing toward each other, it's telling me that's going to be a negative wave. That's going to be a spike. So if I look at that, it's going to be a wave like this. It's going to be a spike because the points are coming together. And that's just nomenclature. That's just the way EEG is set up. That's just a definition. If the points go away from each other, it's not going to be a spike. It's going to be what we call a positive wave, which is not epileptic. So when we're looking at EEGs, we're looking for these types of waves, the waves where the points go together, because that's this pointy wave. And that's something that could potentially cause epilepsy. So that's what we're going to be looking for when we look at our EEGs. All right, let's look at some EEGs. It'll make more sense after we look at some pictures, I promise. So this is what an EEG looks like. This is a normal EEG in a patient. So first, let's get oriented. So this is the bipolar montage. This is the double banana montage that we looked at first. So first, we have to remember that the right-sided electrodes are the even numbers and the left-sided electrodes are the odd numbers. All right, so here we have left-sided electrodes first. These are the ones that go over the temporal lobe. And then we have the right-sided electrodes in the exact same area of the brain. So these first 4 rows of EEG should match the next 4 rows because they're both the temporal electrodes. So they go from the front down over by the ear to the back of the brain. Same thing on the right. Then the next rows of electrode, these are the ones that are higher up on the head. These are ones over the motor strip. And then the right, the exact same areas of the brain. So the first 4 should look like the second 4, and then the third group should look like the fourth group. So you want to compare and contrast and see if things look similar. Then the Z's, remember those are the ones that go right down the middle of the head. So those are the ones at the very bottom. And then this red line is something we don't care too much about, but it's there. This is your EKG. So we always put EKG on because we want to keep an eye on the heart. Every now and then the patient will do something funny, and it won't actually be a seizure, it'll be a problem with the heart. So we do keep one run of EKG there just to keep an eye on it. These ones down at the bottom are the ear electrodes, and we use those for some other references that we look for. Now, when you're awake and you close your eyes, you get a very interesting rhythmic sinusoidal pattern in the back of your brain. It comes from the occipital lobe. And this is this pattern right here. You see this nice little rhythmic pattern? It's not there at the beginning of the page. The patient's eyes are closed, and then we get this nice rhythmic pattern. That's called your posterior dominant rhythm, and that should be a certain speed at a certain age. So we count that. Each of these green lines here is 1 second. This entire page, 1, 2, 3, 4, 5, is about 8 seconds long. So we count and see how many waves are in this 1 second area. 1, 2, 3, 4, 5. It looks like about 10. So that'd be completely normal. An adult should have about 10 seconds of this wave. Kids, it develops as they age. So in children, it's slower, and it gets faster as they get older. So that would be completely normal. So this is a completely normal brain EEG. So what you want to think about is in the front of the brain, each of these 4 electrodes, we go from front to back. In the front of the brain waves are short, and they're faster. So if you look at these very closely, it's a very fast little scribble. As you go from front to back, the brain waves get taller and slower. So each group of 4, the brain waves are short and fast in the front, and as they go back to the back, they get taller and slower. That's just the look of a normal EEG. All right, so what happens when we flash lights? So some of you who have had an EEG have probably had lights flashed when you're in the EEG lab. This down here, these little hash marks, is the flashing light. So what happens to your brain when the light's flashed? Your brain moves in rhythm with the flashing light. So if you look here in the back of the brain, you see that you're picking up a rhythm that's identical to that flashing light. Everybody see that? So here's the flashing light down here at the bottom, and you see a rhythmic pattern here in the back of the brain that's the same as the flashing light. That's a normal phenomenon. That's not anything abnormal. Our brains do that. You don't have to do that, but a lot of us do that when we flash lights. So that's something we look for in an EEG. It's called photic driving. It's not abnormal not to have it, but it's normal to have it. And as the techs increase the frequency of that flashing light, that pattern in the back of the brain increases with the flashing light. So it's kind of a cool thing that our brains do. It's okay if you don't have it, but it's kind of fun to have it. So here's another example. Here's the flashing light down here with the red hash mark, and then here's the photic driving in the back of the brain. Everyone appreciate that? That increased ticking of the brain, right? It's kind of cool. Kind of like a party trick that your brain does. All right. Okay, so what happens when you breathe deep? So when you go to the EEG lab, the other thing they have you do is they have you breathe deep. So why do we do these things like flashing lights and having you breathe deep? Because they can induce seizures in some patients. So what we're trying to do is see if you have something that might trigger an abnormal brainwave or trigger a seizure. So breathing deep can induce seizures and flashing lights can induce seizures in some patients. So that's why we do these things. We're not just doing it to make you feel uncomfortable. So when we have you breathe deep, what happens? Who's had an EEG with breathing deep? Anyone in the room? So how does it make you feel when we do that to you? Okay, does anyone know what breathing deep, how it makes you feel? Well, how do you think that would make you feel if we had you breathe deep for a couple of minutes? You feel a little lightheaded and a little dizzy and a little fuzzy? Yeah. So what do you think happens on your brain waves? Your brain waves get slow. Just like you feel kind of a little slow and a little fuzzy and a little dizzy, that's what happens to your EEG. So if you look here, you see these brain waves are slow. Slow means fat, or there's less brain waves in each second. So if you look at the beginning of the EEG, the brain waves look fine, just like our normal EEG. But then you see here, this area, because my mouse show up on the EEG. Okay, so there's a slowing by the arrow. Okay, so here's some more hyperventilation. There's the slowing with the arrow. So everyone appreciate the slowing? Yes? All right, so now this patient's gone to sleep. So when you go to sleep, you get different patterns on your EEG. So you may see something on that EEG that looks a little different than what we've looked at before. You see some pointy waves that look kind of like those spikes we looked at when we were first learning about abnormal waves right there. So those waves are pointing together, so those look like the spikes that we talked about earlier, but they're not. That's a normal pattern you see in sleep. Those are called vertex waves. So they look just like abnormal waves. They look just like spikes that might be epileptic, but they're completely normal. It's a pattern we see in sleep. They're called vertex waves. In children, they can be very frequent and very active, and we sometimes get patients referred to us to rule out seizures because they had very active vertex waves in sleep. So it's a completely normal pattern that's seen when you're drowsy and going into sleep that sometimes is mistaken for epileptic waves because they can look so pointy and so spiky. All right, what do we think about this EEG? So we have left, right. Does it look funny? Does it look off? Yeah, so remember the brain's symmetric. The sides should be the same. So we have something's off here because the left side has waves and the right side, the lines just look flat. So something's wrong with the right side of the brain. So this is asymmetry. The brain should be symmetric. So here where the purple arrow is, the waves are just flat. They're not squiggly. You should have squiggly lines on your EEG. So something's wrong with this patient's right side of the brain. So this is a patient who had a stroke. So the brain waves are flat because the brain was injured. So it's not making brain waves. So one of the easiest things to look at when you look at an EEG is compare the two sides. So there's very clear asymmetry between the left side and the right side. The right side looks flat, the left side looks nice and good. So this is an injury to the right side of the brain. So the sides are asymmetric. So that's something that can help us figure out what's going on. Now this is another asymmetry. So again, there's something different between the left side and the right side. On the right side where the purple arrow is, you see these big slow waves. Slow waves are the fat waves, where there's less of them per second. This is a patient who has an abnormality in their brain. They have an area of abnormal growth in their brain, a benign brain tumor that's causing these slow waves because there's something taking up space in the brain that's not actually brain tissue. So it causes this abnormal slowing in the brain. Just in one spot. These are all focal abnormalities. All right. This is a patient who has a history of epilepsy, and we're trying to figure out if they have focal or generalized seizures. So we do an EEG and we find these abnormalities here. These are coming from the right side. And if you see, these are points that are pointing together. So these are going to be spikes. These are going to be epileptic abnormalities coming from the right side. So these are focal. They're only on the right side. We don't see them on the left side. We only see them on the right side. So this would indicate that this patient has focal seizures coming from the right side. So that'd be very helpful if the patient comes to the office and all the family saw was maybe a convulsive generalized tonic-clonic seizure. We don't know if that seizure was focal or generalized. This would tell us that the seizure started focal and secondarily generalized. This would help us pick medication and know what to do for our next treatment option. Now here's a patient with the same abnormality on the opposite side. So these are left-sided focal discharges. These are epileptiform discharges on the left side of the brain, focal. Right side looks good. These are only on the left side, just in one spot. Now this is what happened when these patients go to sleep. Look how much more frequent they are. They're coming really lots of different discharges, this time on both sides. So this is sleep activated, multifocal. So sometimes you'd think, well, that must be bad. This must mean that this patient has a worse epilepsy because there's so many abnormalities that you can see coming in lots of different areas. There's actually a couple of syndromes that we see in children where they have this very sleep-activated EEG, and it doesn't mean that the syndrome's any worse. So it just depends on the clinical setting. Sometimes this doesn't mean that the epilepsy is going to be worse or harder to treat. It may actually mean that there's a benign epilepsy going on that's not anything we have to worry about. But it's very helpful to get sleep. We often see more abnormal epileptiform discharges in sleep, so if you only get a routine EEG where you just get drowsy and then you wake up and go home, you may not actually see abnormalities. So an overnight EEG can be very useful for picking up these abnormalities that only come out during sleep. All right, so now we have something different. So this discharge looks completely different than all the other ones we've looked at. What's different about it? It's generalized, right? So we can appreciate the difference. The entire page is changing at once. So we have this abnormal wave here at the purple arrow, but you see it's the whole page. We see an abnormal, sharply contoured. If we look at these little individual sharply contoured bursts, they're definitely sharp, right? Because they look like, look here and here, they're very pointy, right? They look like if you sat up, they would hurt, so they meet our criteria for spikes. But it's a complex discharge. It's a mix of spikes and slow waves, but it's definitely generalized. Right, we can appreciate that that's generalized and it's the whole page of EEG and not focal like the ones we just looked at. So it's very easy on EEG to differentiate generalized from focal. It can be hard when you're looking at a patient who has a convulsive seizure. You may not know if that was generalized or focal, but the EEG is actually very easy. That's very clearly a generalized discharge. No controversy, no weight, no concern. That's definitely a generalized discharge. It makes a big difference. You may say, why does it matter if my child or my family member has generalized or focal seizures? It makes a big difference because we use different medications. There are some medications that only work for focal seizures. And if you give those medications to somebody with this EEG, you're going to make them worse and not better. It's not even bad enough that you're not going to make their seizures better. You actually may make them worse. So that'd be something really dangerous, right? We don't want to give someone medication that's going to make them worse. And then there's medications that only work for generalized seizures that if you give them to a person with focal seizures, it's not going to help them at all. So it's really important that we try to figure out what type of seizure a patient has. So an EEG can be really helpful because this is very clearly a generalized discharge. Yeah. Yeah, so it's a good question. So it can be complicated, and sometimes we'll have, I see my EEG techs nodding their head. Sometimes we'll have a vertex wave that looks like a generalized discharge, and we'll sit there and we'll ponder, and we'll be like, what do you think? Is that vertex? Is that sleep? So you look at a lot of them, and then we try to see if it's, because vertex waves can be sharply contoured. It's more of a call for the person who's reading the EEG. And just your experience and how many you've read. There are some that are very clearly epileptic. And it's like, okay, that's definitely epileptic. And then there's some that are very clearly vertex waves. And then there's some that are fuzzy, where it's like, I don't know, what do I think? So it's really getting a lot of EEG data and really just kind of looking at them and trying to see how epileptic it looks and seeing how many, looking at the whole EEG in total. But there are some where it's difficult to differentiate between the vertex waves and the EEG and the generalized spike and wave. It can be difficult. This one's clearly epileptic, but there are some vertex waves that look like generalized discharges. I certainly have had patients come to me with EEGs where they've been called epileptic, and I've looked at it and been like, oh yeah, no, that's just asleep. And then there's some where I've looked at it and been like, oh, I don't know. And the good thing is if you work in a group where you have a lot of doctors, we come together and we do reviews. And we look at it and we kind of vote, like how many people think epileptic, how many people think vertex waves. You'd like to think that there'd be something clearly at another time, like when the patient's awake, where it clearly shows you something epileptic before you commit someone to years of medication. So this is another generalized spike and wave. Again, clearly generalized. This patient's awake, so this would be an easier one not to be concerned with a vertex wave. Okay, this is another generalized spike and wave. This one's very fast. The spikes are very close together. So this one's very clearly another generalized discharge. All right, let's look at a couple different types of epilepsy, different types of epilepsy syndromes and their coordinated EEGs. So this is a patient with what we call self-limited focal epilepsy. The old name was benign Rolandic. So this is a very common pediatric epilepsy syndrome where kids have focal seizures, usually during sleep, where they have a lot of motor activity. So the abnormal epileptiform discharges usually come from the motor area of the brain. Their EEGs are very active. They usually have bilateral abnormalities on their EEG, and most of these kids outgrow their seizures over time. So the hallmark of this disorder is having discharges on both sides of the brain. So we see independent epileptiform discharges on the right and the left. Now this is what a seizure looks like. So you see this rhythmic activity starting where that purple arrow is on the left side, and if you follow that along that row, the discharge is going to slightly evolve. It starts off a little smaller or shorter, and then those discharges get taller and more rhythmic as you move across the page. So that's a seizure. So a seizure has to evolve over time. It can't just be the same look. You have to have evolution in the shape of the wave and the height of the wave and how fast the wave is. So you can see if you look across that line that wave gets taller, it gets faster, and it gets spikier. So that's a focal seizure. This patient had muscle activity of the right side of the face. So you might be wondering what this stuff is. So this is a seizure here, right? So it starts with the purple arrows, and then this is a seizure. So what do we think about this stuff? Anyone have any guess? All that stuff is? It looks pretty spiky, right? So this is muscle, right? So what's happening? So this patient's having a seizure on the left side of the brain. So how does our brain work? The left side of the brain controls which side of the body? Right, you guys are so smart. So if the patient's having a focal seizure from the left side of the motor, what part of the body is probably going to be involved? The right side. So this patient's having right-sided motor activity. So the EEG electrodes on the right side of the head are picking up that motor activity. So this is muscle artifact. So this is really fast. When it looks this fast, it looks like someone scribbled on the page, muscle. This is all muscle artifact. So it can be a little hard to separate out what's muscle artifact and what's seizure. But that's muscle artifact from the motor activity of the seizure. So if you have muscle artifact on the opposite side of where the seizure is coming from, that may tell you before you even open the video that there's some motor activity that's being caused by the seizure. So that can help you just before you even open the video, you know that patient is probably having twitching of their face because the electrodes that are close to the face are picking up that motor activity. So that's a focal seizure with motor activity on the opposite side. We don't capture too many seizures on those patients in the EEG lab because they don't seize too often. So that was kind of random, pick that up. This is another patient who has a focal epilepsy syndrome. It's called self-limited occipital epilepsy. This patient has abnormal epileptiform discharges in the back of the brain. You see them pointed out there in the occipital area. This is another syndrome that's usually outgrown. Those are focal syndromes with focal seizures. Now, what do we think about this? This is a generalized seizure. So this is an absent seizure. So absent seizures are staring seizures that children have that are usually very short. They have a brief staring seizure. Sometimes their eyes flutter in rhythm with the seizure. If you look here, each of these green lines is 1 second. If you count how many pointy spikes there are in 1 second, there's usually 3. And sometimes when the kids eye flutter, their eyes flutter 3 times per second. It's because their eyes flutter each time there's one of those sharp pointy waves. So these are the seizures that we typically induce with hyperventilation, these brief staring seizures. And these seizures can be very short. They can last 4 to 6 seconds. These seizures come on almost like a flip of a switch. The child may be blowing on the pinwheel, they stop, they have their staring seizure, and then they immediately start blowing again as soon as the seizure ends. And you can see that. It comes on very suddenly. There's not a slow buildup to these seizures. They start and then they stop very abruptly. And that's the same way they stop on the patient. They start and stop very abruptly. This is very clearly a generalized seizure. Why? Because the whole page changes. Right? You don't see it just in one run, in one row. You see the whole page change very abruptly, and then the seizure is going to end very abruptly. So that's a generalized seizure. It's an absent seizure. It's one of the most common seizure types we see in pediatric epilepsy. And these, you almost don't even need an EEG. I can have a child in clinic who they report staring spells. I have them blow on a paper towel. Within probably a minute and a half, they have an absent seizure done. That's the diagnosis right there. And almost all of these seizures are outgrown. This is usually an easy to treat syndrome. Not 100%, but almost all of them. Yeah, of course. Yeah, Challenging. You probably can't, but you can still, these seizures usually are still picked up on EEG. Yeah, you really need cooperation for hyperventilation. Yeah. Yeah, yeah. I mean, the other way that we sometimes get it is when we're putting the electrodes on and the kids cry, which we hate to have kids cry during EEG electrode placement. And EEG electrode placement, if you've ever had an EEG, is not really painful, but kids don't like people touching their head sometimes. So sometimes if our kids cry when they're getting their EEG put on, that hyperventilates them, and then we get it that way, right? So when you're crying, we actually get that same slowing that you see during hyperventilation. We get that when the kids cry during the EEG electrode placement, which, of course, we prefer that they not. I mean, our techs usually, if you've ever had an EEG, we do, when we're in fellowship, we do EEGs on each other. So most all epilepsy doctors have had an EEG done. And it's not painful to get an EEG. It's just when you don't know exactly what's going on and people are messing with your head. And a lot of kids have sensory issues and don't like their heads being messed with. So we do sometimes, unfortunately, have kids cry. But crying is also hyperventilation, So that sometimes does it as well. Yeah, like, yeah.
For children with autism who often sort of go off.
Uh-huh. Yep. EEG. You have to get an EEG for that. So we do a lot of 24-hour EEGs on kids with autism to rule out absence seizures.
If I give this to my son and he didn't respond, then it would be a seizure?
It may not. It's not the only way to know 100% is with EEG. So there's a high risk of seizures in kids with autism. Those two diseases travel together, and the only way to know for sure is with an EEG. Sometimes the eye fluttering that we see with absence seizures is pretty characteristic. So sometimes if there's a video, I look at a lot of videos. People send me videos from all over, so I look at a lot of videos. Sometimes not 100%. I'm pretty good, but I don't think anyone's 100%. Sometimes when I look at the video, I can tell just by the movement of the eyes if it's a seizure or not. But sometimes even that I can't tell 100%. So EEG is the gold standard. Yes? Because they're stupid. That's the only answer. 1 hour is mostly useless. The only time we really get a 1 hour EEG anymore is in our we have a new onset seizure clinic where we see kids within a week of their first event, and we still usually get a routine EEG for that. But after that, it's useless. It's completely useless. The 24-hour EEG is really what everyone should be getting, at least. Now, depending on how frequently you have spells. If you have spells every day, then 24 hours is good. If you have spells twice a week, you probably need a 3-day EEG, which we can get now. We have EEGs, and every hospital has the ability to do EEG within the hospital and in an epilepsy monitoring unit. Plus, all of us have some access to ambulatory equipment as well, where you can actually get it done in your own home. So there's lots of options to get EEG. Yeah, you just have to have the medical provider needs to just fight it. Sorry? You need to advocate. Yeah. Yeah, I'm sorry, there's a hand over there. Yeah. So there's the question was, is there software that reads the EEG? So we do have software. It's interesting. It's a good question. There is software that we have, like spike and seizure detection software. You'd think in the day and age of all the AI and all the software can do, that we'd have really good software that we could run in the background that would identify all this. It mostly stinks, I have to say. And we've had software for years now, and I would think it'd be better than it is, but mostly we turn it off because it picks everything. It can't, as the question about vertex waves and spikes, it doesn't know the difference at all. It marks every vertex waves as a spike. Every time the child moves, it picks it up. It's really very bad. For the level of technology we have in the world right now, the EEG software that picks up spikes and seizure detections, and all the companies use the same. So it's not one company isn't better than the other company. They all use third-party companies. And actually, a friend of mine works for the company who writes it, but they're just not. It's not very good. It's not very good at all. Yeah, it's mostly EEG technologists and doctors watching every minute of the EEG. Yep, that's how we spend our day, sitting in front of computers watching EEG. Yeah.
I actually have 2 questions. What does it mean to have fast activity?
So there's, I think I have a picture of it. So there's bursts of fast activity is usually an abnormal finding, and it's usually seen in patients with epilepsy.
Okay, that's what I figured.
Yeah. Yeah, I think I have a picture of it.
So, my daughter had a left frontal lobe reduction, but they couldn't take out the part that procedures were starting at because it's on her central registers around it. And we know this, I'm just going to say, it's 100%. It's the goal was the seizure would start and then not be able to spread.
Right.
Ever since that happened, she still has the seizures, but it's not showing a lot of EEG. Is that normal?
Yeah, because you can have sometimes the seizures too small to make it to surface EEG, or it's too deep.
Okay, so she would still feel the pain. So our biggest issue now is controlling the pain, but they're also not showing up on the
Yeah.
EEGs like they used to be, and that is wrong.
Yep, it happens all the time.
Okay, 'cause it's just so weird.
Yeah, yep. All right. So this is another generalized seizure. This is a patient with juvenile myoclonic epilepsy. So myoclonic seizure, those are the seizures that are just a quick jerk. So the first page there with the arrow is an example of the in-between seizure discharge, and then on the other side of the page is the actual seizure. The second arrow shows the actual EEG discharge during the seizure. So it can be very similar. You can have a discharge on EEG that doesn't correlate with the seizure, but then the second discharge where it says patient event, that time the patient actually had a quick jerk of their body. So you have to, when you see these discharges, you actually have to take time and open the video and watch to see if they're having a seizure or they're not, because the EEG pattern can be very similar between when the patient's actually having a seizure or when they're not having a seizure. So it can be very time consuming to watch all these videos and try to track down which ones are seizures and which aren't. This is only a second and a half long, so these are very short seizures that you may miss if you're not looking at the patient. What happens is these patients have these quick muscle jerks, and often they drop things and the parents just think they're clumsy because they're dropping things all the time when actually they're having these little seizures. And then this is an example of a drop seizure. So these are patients who have, oh, I don't have an arrow, sorry. So where it says drop, those are the seizures. So this is another EEG pattern, again, a generalized pattern where you see that clear change in the EEG. Again, it's a spiky discharge with a drop. Here you can see some fast activity. The question about the fast activity is right here. Oh, cool. This really fast scribble, that's fast activity.
And then what's next?
This happens to be a drop seizure, but we see it with a lot of different types of seizures. That fast activity is at the end of the page there. Okay, so this is a generalized tonic seizure. So remember, tonic seizure is the type of seizure where, wait, is it still up? Tonic, yes. So it starts right under the word tonic. So you see the whole page, this almost looks like a muscle artifact, right? Don't we agree? It looks like the picture I showed, a muscle artifact. It's slightly different. So a tonic seizure is when the page is, there's a lot of fast, almost like a scribble, but that's a tonic seizure. Okay, and then just have, I think, two more. So this is a tonic-clonic seizure. This is a patient having a full-body convulsive seizure. Again, it almost looks like scribble on the page, but it's, again, another generalized seizure with a lot of those spiky waves. What time am I done? Am I over? Tell me what time I'm done, because I can... Okay. Okay. You have a few more. Okay. All right. This is hypsarrhythmia. So anybody has a patient who has infantile spasms, this is what hypsarrhythmia looks like. Hypsarrhythmia is the abnormal EEG pattern we see in kids with infantile spasms. So this pattern, we describe it as chaos. And you can see that. So you remember the very original EEG we showed that was the normal EEG pattern where everything was nice and organized. We had nice 4 rows of normal brain waves where they looked all nice and organized. This looks like if you looked at it upside down or right side up, it would look the same. It's that chaotic and that disorganized. So this is a very abnormal EEG pattern. The interesting thing about kids who have infantile spasms is their EEG is abnormal even when they're not having spasms. So you don't need a really long EEG to figure this out, because as soon as you turn the EEG machine on, they have this very abnormal pattern called hypsarrhythmia. So it's usually a very easy diagnosis to make. Now, what happens when they have their spasms? Here's the spasm right where that red line is. Look, the EEG actually looks almost normal during their spasms. So you have almost this pseudo-normalization where you have this kind of flattening of the EEG, and again, you have some fast activity. Fast activity is where the pen scribbles really fast. So the spasms, the EEG almost looks more normal because the in-between EEG pattern, this pattern we call hypsarrhythmia, is so abnormal. The key to treating spasms is not only to get the spasms better, but fix this EEG. If you don't get rid of this hypsarrhythmic pattern, the patients aren't going to develop. So we have to do both. We have to get rid of this very abnormal pattern and get those normal brain waves back. If you don't have normal brain waves, you're not going to be able to think and learn. So this is a really abnormal pattern that we really want to keep an eye out for and make sure we treat. Okay, this is another very abnormal pattern. As you can tell by looking at it, we don't see any of our normal organization. We see, again, a lot of chaos, but instead we have a lot of these spikes, these pointy waves here we see at the top, and they're mostly in the front. This is Lennox-Gastaut, which is another very abnormal EEG pattern, a syndrome that we see in kids with challenging epilepsy and intellectual disability and very bad seizures. So this is a very rhythmic frontal pattern with these spikes and then these aftergoing slow waves. It again looks kind of chaotic and very disorganized. So another very abnormal EEG pattern. Let me skip that. Okay, then this is a pattern I like to show. So this is electrical status epileptic is asleep. So I don't know if anyone's ever heard about ESES. This is a pattern that we see in kids. The classic syndrome is Landau-Kleffner, where kids have normal development and then lose their language somewhere around age 5. And when they go to sleep, they have this pattern. You can see how abnormal this pattern is. Right? This doesn't look anything like our normal EEG. You see these really almost generalized spikes that come almost, like if anyone played an instrument growing up like a metronome, you can almost set it to this. They're almost every couple every second. This is continuous when these kids go into a stage of sleep called slow wave sleep. So these are kids who aren't having a lot of seizures, but they've had a clear cognitive decline. So when we see this pattern in someone who has cognitive decline, plus or minus seizures, and this pattern has overtaken their sleep, this is something we have to try to fix. And it can be fixable. It can be fixable with seizure medications. So anytime we hear a story of someone who's had cognitive decline, especially with a history of seizures, you have to get an overnight EEG. This is back to your story of the insurance companies. You will never pick this pattern up in a routine lab. Why? Because almost nobody goes into slow wave sleep in a routine lab. Because you don't have time. It's a short study. As soon as you get drowsiness, the kids are woken up and sent home, or adults. I'm a pediatrician at heart, that's why I say kids. But you need slow wave sleep for this pattern, and you're not going to get it in a routine lab. So if you have patients who have had cognitive decline, have lost their skills, have a history of seizures associated with that, you have to get an overnight EEG to get this, because we can fix this, and we can get that development back. But we can't fix it if we don't know it's there. And the problem with ESES is the faster you treat it, the better luck you have at fixing it. So if you wait too long, you're going to have trouble fixing it. So this is a really easy pattern to see. Right? This is not something someone's going to miss. Even the most junior epileptologist or EEG reader is going to see this, because they may not know what to do with it, but they're at least going to see it and be able to call someone and ask questions, because it's so abnormal. So anyone who reads EEGs is going to be able to pick this up and at least be able to call for help. So something we really want to focus on. All right, a couple of seizures. This is a focal seizure coming from the right temporal lobe. You can see the rhythmic slowing. You can see it down there at the bottom as well. This is probably easier to see. This is a left temporal lobe seizure. So again, focal seizure is one spot. I'm going to put the arrow up. So there's the arrow. This is an electrode sitting right on the left temporal lobe, the purple one. You can also see it at the top of the page. You see it right here. Focal seizure. So this rhythmic discharge. You can also see it down here. This electrode is sitting around the temporal lobe. So focal, just in one spot. If you look at that discharge from the left page over across to the right, you see that it evolves. The discharge gets higher, it gets spikier, and it gets faster. So that's a seizure evolution. Seizures always evolve. They evolve in the shape of the wave, they evolve in the height, and they evolve in the speed. So that's a focal seizure. You see the right side of the brain doesn't seem to even know what's going on. It's just coming from the left temporal lobe, just minding its own business, just seizing there in the left temporal lobe. All right, these are just some seizures. I think we're out of time. All right, let me stop for questions. I just had some more seizures, so we'll stop. We won't show the rest of the seizures. We'll stop for questions. I'll stop for questions so I don't go over. We took some questions during it, but more questions? Huh? Oh, sorry. Yeah, I'm not even looking. Yes, please. I mean, I think there's people in every hospital who treat it just because it comes up everywhere. I don't know that there's any one spot that's really considered experts. Yeah. Oh, that's a good question. It does, yeah, because the hemispheres aren't talking to each other. So yeah, we definitely see differences. That when there's seizures, they don't spread between the hemispheres as easily, especially if it's a complete callosotomy. So there's EEG board questions that have an EEG after a callosotomy, and you have to be able to figure that out. So yeah. Yeah, I think it's variable. I think I've had some. So when we bring patients into our epilepsy monitoring unit to kind of catch seizures, I've had patients go their longest seizure-free ever. Like I've had patients who seize every day and then come in and go 5 days seizure-free. I'm like, what happened? So, I mean, I think it's hard. It's variable to what you're going to get on EEG. There's sometimes we catch things, sometimes we don't. You know, sometimes you get lucky, sometimes you don't. I'm not sure I understand the question. Yeah, yeah. So the pattern, the LGS pattern should be there all the time. That's an in-between seizure pattern. So that's the, yeah, sorry. Thank you for clarifying. That's the, I mean, it's not everybody with Lennox-Gastaut has to have that exact pattern, but that's the kind of in-between seizure pattern that we see in most patients with Lennox-Gastaut. Like if you wanted to get into a drug trial for Lennox-Gastaut, they look for that pattern on your in-between seizure EEG. And then you also have to have certain seizure types. So that's kind of the in-between seizure pattern that we see in most patients. It's not 100% in every patient, but that's what your EEG should look like in between your seizures. Yeah, sorry, yeah. Uh-huh. So those are the sharp waves. Those are those pointy waves. It's the in-between. So the spikes are the pointiest. Sharp waves are a little less kind of bad. So it just means that there's some irritability in the temporal lobe that says she may have seizures coming from the temporal lobe. So it's not actual seizures. It's a sign of irritability coming from the temporal lobe that was activated by sleep. So it's an increased risk for seizures coming from that temporal lobe. So when we go to sleep, we have drowsiness, and then we go into a little bit deeper drowsiness, that's stage 2, and then we go into deeper sleep, which is like slow wave sleep. So we see most of the abnormal epileptiform activity in stage 2 sleep. It's just like deeper drowsiness. Yeah.
Can you talk about the slowing, intermittent slowing that we might have?
Yeah.
Like,
Yeah. We see it, intermittent slowing is a very common finding. So we see it for a lot of reasons. So probably the most common reason we see slowing in someone with seizures is because they've had a seizure. So after a seizure, your brain goes to sleep until it recovers, and that looks like slowing on EEG. So that's probably the most common reason. You can also have slowing if you have something structurally abnormal in your brain. So either a tumor, an area of cortical dysplasia, abnormal brain development if you've had a stroke, anything abnormal on the MRI can show up as slowing on the EEG. You can have slowing if you're on medication. Sometimes, and you think medication should cause slowing everywhere, but sometimes it doesn't. So that can cause slowing. Sometimes there's slowing for reasons we don't know. We just see focal slowing and we never find an answer for it. The most important thing to do if you see focal slowing is to get an MRI if you haven't had one, because the most common reason for focal slowing is something in the MRI. So that's the first thing we always look for. But if you don't find anything on the MRI, it may just be the way the brain's working. That area of the brain may just not be working as well as the other areas, and that may cause the focal slowing. So there's a lot of different reasons for focal slowing. The most important thing to rule out is something abnormal on the MRI. Mm-hmm. It's a good question. If you capture, so the gold standard, if you capture an EEG, a seizure on EEG, then you know for sure you have seizures. So that we can say with 100% certainty. If I'm doing an EEG, the patient has a seizure on EEG, I can say, yes, for sure you have seizures. If I don't see something on EEG, I can't tell you for sure you don't have seizures, right? It doesn't work that way. And the frustrating thing is this other family was saying is sometimes seizures come from so deep in the brain, they don't make it to the surface. So you can have your typical event, and I don't see anything on EEG, and I can't tell you 100% for sure that wasn't a seizure. Because if it's coming from deep in the brain, an area our electrodes don't cover well, it may definitely be a seizure, and I just can't tell you for sure. So I think some people get an EEG and they don't see something and say, oh, that's not a seizure. You can't do that. You can't say for sure it's not a seizure because the EEG may just not have picked it up. There's a lot of reasons why that happens. So yeah, it's frustrating. Yeah. Yeah, you can. Yeah, it can be a little challenging, but usually you can. Yeah. Yeah. All right, thanks, everyone.